Welcome to one and all, and warm greetings to all of you from Cipla Urology. We would like to welcome all the delegates who are attending this conference live with us, and we are honored to bring you such an academic program today from the House of Cipla Urology. I would firstly like to thank our moderator today, who is Dr. S.K. Raghunath, for coming up with this idea of having a webinar on a subject which is less discussed and having a format which is more of a discussion instead of a didactic lecture. So again, a warm welcome to all of you for experts' perspectives on management of locally advanced and oligometastatic disease. To start with it, I would firstly like to introduce the moderator for this meeting, which is none other than Dr. S.K. Raghunath. Many of us in India know him, but since many international delegates would also attending this program, Dr. S.K. Raghunath is a practicing uro-oncologist, consultant uro-oncologist, and robotic surgeon in India. He has completed his MBBS and MS from Mysore in Karnataka, followed by which he did his DNB in urology from prestigious Muljibai Patel Urology Hospital. Followed by that, Dr. Raghunath also spent 2 years in fellowship in Rajiv Gandhi Cancer Institute, in which he did his fellowship in uro-oncology. With keen interest into surgical domain, he followed this up with a fellowship in laparoscopic and robotic surgery. This was done in Taiwan, Taipei. He currently practices as a senior consultant urologist and robotic surgeon out of 2 institutions, which is one HCG Cancer Center and Trustwell Hospital, Bangalore. Dr. Raghunath brings with him extensive experience of more than 20 years, across which he has managed many complex uro-oncological procedures, which have been more than 4,000 in number, which includes all types of open, laparoscopic, and robotic surgeries. Apart from this, Dr. Raghunath is also involved in multiple clinical trials and has been an investigator in more than 20 such trials. With this, without taking much ado, I would like to hand over this session to our moderator today, that is Dr. S.K. Raghunath. Over to you, sir.
Thank you, Mr. Kaustubh. Very good evening. Warm welcome to you all. Welcome to this expert perspective, improving the outcomes of managing locally advanced and oligometastatic prostate cancer. Why did we choose this topic is, most commonly we see in India locally advanced and oligometastatic prostate cancers. So to throw light on these things, we have expert faculty, that is Professor Tombal, and objectives of this meeting is to refresh understanding of LAPC and oligometastatic prostate cancer, to review the available treatment options and its benefits and pitfalls, to get expert opinion on clinical questions. So it's my honor and privilege to introduce Professor Tombal. He's the chairman of the Division of Urology and Professor of Urology at University Catholic de Leuven, Brussels, Belgium. He obtained his MD from the same university and PhD again from the same university in 2003. His primary clinical interest is the treatment of advanced stages of prostate cancer, and particularly hormonal treatment and development of new biological agents. He's heading the uro-oncology division at UCL, where he is coordinating several trials in this research area. Professor Tombal has authored many published papers, books, and book chapters. One interesting and important thing to note is, since September 2017, that is from last 4 years, he is the president of prestigious EORTC. We go through all these EORTC trials. So he is the president of European Organization for Research and Treatment in Cancer, a leading European academic research organization in the field of cancer. So with this brief introduction, I welcome Professor Tombal to this webinar. This is a very interesting webinar because this locally advanced prostate cancer and oligometastatic prostate cancer is not very much discussed. We don't know what is the right treatment for this particular subset of patients who present with this. So to answer all our questions, to clear all our doubts, we have Professor Tombal. I welcome him again. And without much delay, I would like to start our discussions. So I would like to ask the first question to Professor Tombal. Professor Tombal, what do you mean by locally advanced prostate cancer?
Hi. So first of all, thank you for inviting me. So that's indeed an interesting question that we had here in Europe for many years. I'm just going to show you one slide actually where, okay, tell me if you see the slide. I think it should be
Yes,
okay.
yes, we do.
So I'm going to do this. You see, actually, we did that survey in 2014, and we had what, you know, that locally advanced has been replaced by high risk and very high risk. So basically, it is everybody which doesn't have metastasis. So that's easy. I'm 0. And then the big question come, where do you put the limits for lymph nodes? Because you remember that initially it was only pelvic lymph node. And if you look at modern definition, like the one from the NICE in the UK, they basically extend. So I tend to say that locally advanced is somebody who doesn't have bone or visceral metastasis. And why? And even so, the question will change, because basically the question, there's always a reason to say, why do we have this definition? Historically, we had this definition to know who needs local treatment and who needs hormone therapy. But as you know, today it's more complex. We do even apply local treatment to oligometastatic patients. We're going to discuss that later on. So to me, basically, the definition of locally advanced prostate cancer is somebody where you still have a chance to actually recommend local treatment. So these are the patients who don't have any visceral metastases. To me, lymph node, and I would say abdominal lymph nodes, I would say certainly N1, and some N2 should not be considered as metastatic. No, if you have big metastases, we have seen patients with metastases here, subclavicular lymph node, these are metastatic. But to me, locally advanced should be defined by the opposite, by to say the locally advanced are those that are non-metastatic. And metastatic, it is like the stampede definition. This is metastases in the liver, in the lung, or in the bone. All the rest, we should skip to the stampede definition. Patients with lymph nodes are also locally advanced patients.
Okay, thank you, Professor Tombal. My second question is involvement of the pelvic and lower retroperitoneal nodes considered as LAPC, or lower retroperitoneal nodes considered as oligometastatic disease? So first, let us address only the locally advanced prostate cancer. Then probably in the second session, we can discuss about.
Yeah, we can discuss. So to me, these patients are locally advanced. There was just today, I hadn't time to prepare, but still today, there was a very nice paper in Lancet Oncology by a group of Belgium speaking about, and we may discuss that later on, about prophylactic whole pelvis irradiation. And I think that lymph node, with my resident, I have a very simple explanation. I'm sorry, it's very basic. I say, you know, everything that is below the belly button, that's locally advanced. When it starts to be like above the renal artery or above the superior mesenteric artery, that's getting tricky. But lymph node, and especially pelvic lymph node, this is locally advanced disease. This is not oligometastatic. And that's going to be important when we're going to speak about treatment, about the role of surgery, about the duration of hormone therapy. These patients are locally advanced patients.
Okay, so involvement of the retroperitoneal nodes, though it's classified as M1A according to TNM classification. So does it come under locally advanced or oligometastatic?
I think that this whole classification actually is, because M1A is a lot of patients, I would consider that those who have lymph node only, right, limited to the abdominal cavity, whether you call them oligometastatic or locally advanced, you should treat them like locally advanced. This right. is important. So I would tend to say people may disagree. Some will say M1A, some will say locally advanced. But anyway, they should be treated like locally advanced disease, meaning local treatment is important.
Right. So can you throw some light on what percentage of this subgroup of patients you see in your practice?
30%. That's easy because actually in Belgium, we don't have a very high, we don't recommend PSA screening too much. So I would say that 30%, it's 30, 30, 30, 10. That's always what I said. It's 30 low risk, 30 intermediate risk, 30 locally advanced and high risk, and 10% metastatic upfront.
Okay, so in India, we do see differently.
Yeah, that I know.
Predominantly, we see metastatic. Then nowadays, we do see locally advanced, even organ-confined prostate cancers. Nowadays, we do get. That's how we do more radical prostatectomies nowadays with the advent of robotic systems in India. So our numbers are also increasing. We are more and more, going to get more localized and locally advanced prostate cancers.
Yeah, what is happening also is that as you mentioned, when presenting me, I've been working 2 years in Johns Hopkins with Patrick Walsh, and I came from Belgium, where my tutor was Paul Van Kamp and Hein van Poppel, which is very well known, and we used to operate on locally advanced disease. We used to do extensive lymph node dissection. So when I came to the US, it was a shock for me to realize that they were not doing surgery on these patients. Surgery was only for, the limited intermediate risk patient with good prognosis. So I was very surprised with it. So I think there's been a double phenomenon. In country like India, you are now detecting patient a little bit earlier, but also everywhere on the planet, we are doing local treatment, especially surgery, in more and more advanced patients. So that's indeed, today, we don't do any surgery in low risk. Intermediate risk, we don't do surgery. We do brachytherapy, radiotherapy. So 95% of our radical prostatectomy are high risk or locally advanced prostate cancer. So this is really the number one patient for multidisciplinary approach that involves surgery, and we're going to discuss that later.
Okay, is the prevalence same from last 1 or 2 decades, or it's changing? Any changing trends?
It seems to be. It seems to be increasing, and we can't explain that. Is it because we do less PSA, because there was a lot of misinformation in general practitioner? Although when we look at the number of patients that are diagnosed in Belgium, it's always the same. But we see a trend, and it has been shown in the US as well, to see more high Gleason and more locally advanced disease, high risk, very high risk patient.
That's what we see in our country as well.
Yeah, and also and we're going to speak to that also, with modern imaging technology, we see many more patients with lymph node deposit. So, so that's why we do more and more extensive surgery and radiotherapy.
So after understanding the locally advanced prostate cancer prevalence and what exactly is the meaning of LAPC, what are the treatment options available for locally advanced prostate cancer, Professor Tombal?
So I think there are a series of messages which I used to give to the patient. I think that, first of all, local treatment is critical. I remember when I came to the US, especially, those patients with very advanced disease, they would receive only hormone therapy. I think that has been shown by EORTC. Professor Studer has done a beautiful trial showing that if you don't do local treatment, hormone therapy, it will not increase overall survival. I mean, it's whether you start it early or late. So hormone therapy is not a curative treatment. So if the patient is not in shape of having local treatment, you should probably not do anything. So I think the first and important message is you should think about local treatment. And then basically, there are two choices. Either you go to radical prostatectomy, but if you go to radical prostatectomy, it is very important to explain to the patient that it's the first step of a multidisciplinary treatment. Because sometimes I have colleagues, they remove the prostate of a patient with a Gleason 8, 9, then the patient has positive margin and he comes for a second opinion. He say, oh, that was a bad surgery. I say, no, it was a bad explanation. Right. It was a good surgery, but you should understand that you're going to need more than that. And then you have to discuss what is the benefit of surgery in such case. And actually, this is something we have studied a lot in Europe, together with Stephen Jonio, Alberto Briganti. We have actually now a series of more than 8,000 patients with high risk or localized disease who have been treated in 8 centers in Europe. This is the first paper we published in 2015, where you see that actually with surgery as a first step, if you take all the high risk, you have an overall survival at 10 years, which is close to 90%. And if you take the worst patient, those who have a PSA above 20, T3, you still have reasonable overall survival. So that's important because your patient, they're going to live long enough to benefit from surgery. So I tend to believe that if you see the patient, you do a digital rectal examination, which to me remains the best exam. Right. You feel whether the sphincter is invaded or not. The bladder neck, it's never a problem. You don't care. You can remove 2 centimeters of bladder neck. You don't care. If the sphincter, if the prostate is still a little bit mobile and the sphincter is free, then you can go to surgery. If not, it is better to go to radiotherapy plus hormone therapy. Now, what we see a lot in Europe in the last 6 months, 1 year, is to say there is no hurry to do the local treatment. We're going to start by 3 to 6 months of hormone therapy. And usually we use LHRH antagonist for this. We're going to give 3 or 6 months of hormone therapy, and then we're going to re-examine the patient. Because what we notice is that a lot of these patients will have a massive shrinkage. And it's going to help the surgeon and the radiation oncologist because radiation. And so when the patient is, or the surgeon is undecided, we don't know surgery, we say, okay, let's wait. Let's do 2-3 months of hormone therapy. And then let's start surgery if feasible, if not radiotherapy. If we go for surgery, then we stop the hormone traditionally after the surgery. We look at the lymph nodes. If the lymph nodes are negative, if you do surgery, you have to do an extensive lymph node dissection, otherwise it's useless. And then we look. If the patient has no positive lymph node, then we tend to stop. No, today there was a paper in the Lancet, a nice study coming from the US, that showed that in very aggressive disease, maybe you should discuss immediate adjuvant pelvic radiotherapy. So that's what we call in our center the full Monty. When we have a young patient, like here, the latest one was a internal medicine doctor from here. The guy is 57 years old, first PSA ever, 100, Gleason 8, T4, positive lymph nodes. We did 6 months Degarelix. He had his surgery 3 months ago. He had 2 positive lymph nodes. We did surgery plus 6 months hormone therapy. Then we're going to stop everything. So to me, the discussion, surgery, radiotherapy, if you've got a good radiation oncologist who know oncology very well, he's going to tell you, in many cancer, patients get both. Take, for instance, breast, rectum, lung. So the radiation oncologist, the good one, they are okay, you go first for surgery. So that's why we tend to do more and more surgery. No, if the patient is, to me, the limit is the chance of preserving the continence. If you know from day one you're going to cut in the pelvis and the thing. No, you don't do that. So if you feel, and with modern technology, and honestly, with robotic surgery, it's not more complicated, and because you don't care about the nerve, so you cut. So this is really the trick. If you can preserve the sphincter complex, surgery would be my favorite option. If not, but when you do surgery, you explain to the patient that it is the first step. And I usually tell them, even if it's not true, I tell them you've got 50% chance of having radiation therapy. So they are ready. And
Right.
if you say you don't need radiotherapy, then they're happy. But if you say you need radiotherapy, okay, that was expected. And those we don't go for surgery, we go for radiation therapy.
Is there any age limit to do surgery? Up to what age or what life expectancy you consider?
So in my country, we cannot speak about age anymore. This is considered as a discrimination. So we use the G8 score, which is a score assessment, and we send the patient to the physiotherapist.
Right.
And then the physiotherapist, he examined the guy, and once again, the only problem with age is incontinence. Right. And so my physiotherapist, they're going to look at how the guy is able to move his pelvis and whatsoever. And it happened that they will say for a 70-year-old guy, don't do surgery, never going to be continent. And we did do surgery to an 83-year-old guy 2 weeks ago, but the guy was biking every day. I mean, he was still doing his yard, very active. And what's good with old people is that usually sex is not really an issue. They don't care about that. The only thing they care is their continence. And to me, and I mean for any surgery and any treatment anyway, we never speak about age because we realize that we have guys 65 years old who do poorly. And in Belgium now, we have more and more patients. I mean, most of the patients I see in my clinics are above 75. It's the same for bladder cancer. We see very old patients, and actually, you're very surprised that they're very good at day 6. At day 5 after surgery, they're home, they're doing their yard. So the only difference is that above 75 years of age, we do a more comprehensive evaluation. We look at cognitive problem, because if they have Alzheimer or things like that, they're never going to get continent. And we look at everything that will compromise continence. That is neurocognitive disorder, poor muscle capacity, but many of them don't have that. Then you can do. Why would it be different? I mean, no, so we don't speak about age anymore.
Right. So according to you, then the only contraindication for surgery is sphincteric involvement. That's right? Yeah.
And also that's what I call the surgeon impression. Okay.
Right.
You have to understand that, and I use that. I mean, it's Professor Van Poppel who always speak like that. The radical prostatectomy you do with the robot to a 55-year-old guy with a low-risk disease has nothing to do with the prostatectomy we are speaking here. He was calling that XXL prostatectomy, meaning you have to go very broad. So you have to use.
No, we can discuss all those technical modifications, all those things.
Yeah,
in the next question.
And you have really you really have to get that impression. I mean, here in my hospital, we have a great surgeon. The guy is not even 50 for sarcoma. He's one of the top sarcoma surgeon here in Belgium. And it's very funny because, you look at the CT scan, you look at the patient, and he knows whether it's feasible or not.
Right.
So there is in surgery that kind of feasibility element that is very hard to teach to the pupil. That is something you only acquire by experience. So if you do one of these 2 prostatectomy a year, that's not going to go. You have to do a lot. And you have that kind of technical feasibility thing, meaning the ability to have the idea that the patient will be incontinent. And in such case, you don't do it.
So how many surgeries you recommend in a year to get that perspective, to get that experience to come about
I
these
would say
things?
that the minimum, my boss always said, you need to have done 500 to be very sure. And
Right.
you should do like, that would be, I would say a number. I think that the guy which is doing one a week for 5 years is better than the guy who did 100 over a year.
Right.
Is that idea to do it? You know, the sarcoma guy in my in my hospital, he do one sarcoma a week, but it's, you know, it's kind of it's metronomic. It's always the same. So I would say you need to do minimum once a week. That would be the strict minimum.
Okay. Okay. Thank you, Professor Tombal. We discussed about all these things, the treatment options and all. What does the guideline says? EAU and American Urology Association guidelines tell about locally advanced prostate cancer. Do they talk about surgery or
Yeah. So
treatment
what that's been like this forever. They say the reference treatment is radiotherapy plus long-term hormone therapy. Okay, so radiotherapy plus long-term hormone therapy, and surgery is an option in acceptable case. And they use the word well-selected case.
Right.
Meaning that the danger is to say, if you say surgery is the number one option, everybody will do it.
Right.
Also, the one who does not do a lot. It's been shown it's the same for retroperitoneal lymph node dissection after testis cancer.
Right.
If you have to choose between RPLND and testis cancer, what's going to drive the choice is your surgeon. If you have a surgeon who do a lot of this, then it's better to do surgery. If you have a surgeon which is not used to that, then do chemotherapy. For the prostate, it's the same. The guidelines say two important things. You should do local treatment, and reference treatment is radiotherapy plus hormone therapy 2 to 3 years. And they say then in high volume center, well-selected patients are candidate for surgery as well as part of a multimodality approach. That's the trick.
Right.
So surgery is an option by guidelines, and they don't put the selection on the patient. They put the selection criteria on the surgeon. That's all you have to see it. If you feel comfortable, you can do it. If you don't know where you put your feet, then you should not do it.
Okay, I would like to discuss one example. A 60-year-old gentleman comes with locally advanced prostate cancer. He does not have any comorbidity. It was discussed in the multidisciplinary tumor board. Radiation oncologist says, as per the guidelines, I would like to go for hormone therapy and radiotherapy. Whereas the surgeon says, since he is young, better to go for multimodality and surgery should be the first therapy. So when this kind of arguments comes, how are you going to tackle?
It goes because there was never a trial comparing the both. When you don't have a trial, which really allow you to say these patients were better than other, you are confronted into a corporatist approach, okay? And that's where it's becoming complicated. That's where we have a multidisciplinary setting. That's why in locally advanced disease, we say in the end, it should be a discussion with the patient, okay? Because there are advantages and disadvantages to surgery. With surgery, for instance, you have a higher risk of incontinence, but when you're gonna become metastatic CRPC, you have a lower risk of urinary complication. So once again, we tend to say both options are good options. We have both good radiation oncologists. We have good surgeon. Let's speak with the patient. Let's speak honestly with what we can offer. And then it's very, very funny that it's very rare that a patient is not choosing. You have patients, they will feel relief by the idea that the tumor is gone, even if we know it's not enough to cure them. So I think that when you don't have trials, to tell exactly what patient need what treatment, you have to be able to explain that uncertainty to the patient. And very often we sit together with the radiation oncologist. And I must say, she's a pretty lady. So I have a major disadvantage in the discussion because they always look at her and not at me. But most of the patient, if you explain really, this is this, this is that, they're going to make their own choice. So I don't worry about that. And I explained that we were stupid. We never did a good trial. So we know both options are good. And then I tell them, all the rest, it's quality control issue. You have to trust your surgeon. You have to trust your radiation oncologist. But we're going to have to make the choice together. And I'm very privileged because I have two oncological nurses that work with me for more than 15 years now, and they are very good at that. And they can often tell you after 5 minutes, they know already what treatment the patient will go for. Because once you explain that we are speaking about locally advanced disease, we are speaking about a threat to your life. We understand that, you know, sexuality is important and all of that, but please understand that that's going to be a multidisciplinary approach. Once you explain, you say, okay, we can start by removing the prostate, okay? Right. What is the problem of removing the prostate? It's a surgery. It's a big surgery. And you may get more incontinence at the beginning. What is the benefit? Is that over the long term, when you're going to progress, you're going to have less urinary symptom. That's been shown. And then slowly you speak to the patient and they make their own choice.
Right. So in case if patients and radiation oncologist decides to go with hormone therapy and radiotherapy, for a locally advanced high risk, of course, Gleason score is say 4+5. What is the natural course of the disease? What will happen after giving hormone therapy and radiotherapy? What will happen to, if you take 100 patients, what will happen to those 100 patients, say 5 years or 10 years down the road?
Yeah, that's what interesting. If you take, because basically the problem in the trial with locally advanced and radiotherapy, and we know that very well at EORTC because we've done a lot of trial by Professor Bola, you have two groups of patients. You have the group of patients that, you know, were actually eligible for surgery and had radiotherapy. So these patients, they do in a similar way that the surgery patient do. We do estimate that usually after 10 years, 85% will be alive, okay? Right. And that 30% will be receiving hormone therapy. We have shown that the 85% overall survival we show in the impact studies include 40% of patients that are on androgen deprivation therapy, that you had to restart androgen deprivation therapy. If you take the higher risk locally advanced, those with lymph node that unfortunately at 5 years, more than 50% are back on ADT. So that's where I like to tell them that we are more coming close to the oligometastatic, where we do kind of intermittent hormonal therapy. No, it's going to change because we're going to have the new molecule in that setting as well. So actually, if you go to a paper, the Latitude, the Stampede paper by Abiraterone, and you do, because you know the company Janssen, they spoke a lot about metastatic patient, and you say, no, I'm going to go to see the locally advanced patient. And you realize they are English locally advanced patient. So very similar to India, high volume disease, N1, PSA above 40, T4 disease, so real locally advanced cancer. Radiotherapy, like they give in the UK, basic radiotherapy, lymph node, prostate, 2 years of abiraterone and ADT. And then you see at 5 years, 95% are without any PSA recurrence. So I think that in the next 5 years, these locally advanced, we will increase the multimodality part. So what I call the full Monty, or the Holy Trinity, which is surgery, radiotherapy, and hormone therapy, will be with this new hormone when the price is going to go down. And then we're starting to have the opportunity to have very good survival. So I think that as long as you don't have any bone or visceral metastases, there is the opportunity to control the disease, so that I would say overall, we know in our center here, 70% are alive at 10 years. But many times you need multiple treatment. You need radiotherapy, then you need, because the problem, if you skip surgery, you have to take into account, you know, the local recurrence, the TURP, the JJ stand, the suprapubic catheter. And I'm the Department of Surgery here, and we have a big retroperitoneal unit. And actually, they are always so surprised that prostate cancer is the one where we do, in the end, the less surgery. Because, I mean, and any other cancer, rectal, I mean, first you go for surgery and then you do something else. So I think that surgery is already and will become more and more important in that category of patient who can have very localized advanced disease, including lymph node, but have no metastasis. So that, I'm sure, will be the future.
Yeah, you brought this very important and interesting point that the newer drugs, abiraterone and other things are available. I would like you to throw some light on this. So when do you advise abiraterone and enzalutamide, and which is better between these two drugs? So you do.
Depends. I mean, first of all, they all work the same way. Okay, so they are very effective. We have seen incredible things. Huh? I have patients that are in the clinical trial. I had a patient, he used to work in the hospital. He was 82 years old. He had a PSA at 1,000. He had multiple bone metastases. He had been castrated for 5 years. He's been known on abiraterone and he's still alive. He's been on Abi for 7 years. He's 89 years old. He's very good. So all these drugs are equivalent. I think that there are 3 points on which you have to choose. The first one, very important, even in my country, it's important, it's the price. There is a price competition between the drug, okay? So, and generic will drive this price competition. If a drug is more expensive than another, usually it's more expensive than the real difference in terms of efficacy. So go for the price. Second, go for the tolerability. If your patient has diabetes, he has hypertension, cardiovascular disease, don't give abiraterone. You're going to cure his prostate cancer, but he's going to die from cardiovascular disease. Go for Enza. Right. If your patient is a little bit older, he's got already some fatigue, go for Abi, because then he's going to be much better. And then the third one is the convenience. To be honest, enzalutamide, apalutamide, it's like, you know, bicalutamide. The only difference, there are two differences, the efficacy and the price. Imagine that enzalutamide is 80 times more efficient than bicalutamide, but the price is 200 times more expensive. So that's the problem. If enzalutamide would be the same price than bicalutamide, nobody would speak about abiraterone. We will all give the drug. So, and I think in the future, with many generic coming, and I know in India you have a lot of generic coming, we're going to use more and more these drugs. And very interestingly, and that's another topic we don't address today, we could spend 1 hour. And it's been shown by the Japanese already 20 years ago. Those who benefit the most from the combined treatment are the locally advanced disease, positive lymph node, over a short-term period together with local treatment. So exactly like you see in the Stampede trial. Once again, Janssen did a lot about the metastatic because it was a latitude. But if you read the paper and you forget about the metastatic, and you see the hazard ratio, the benefit for the low risk, that's unbelievable. So that's going to be, and honestly, 2 years will still be affordable. So because they're going to, so that's really where we're going to go with these new drugs, I would say in 5-6 years from now. And then for we, the urologists, it's going to be a huge opportunity together with the radiation oncologists to rethink, and especially in country like yours, where you have a lot of locally advanced disease, you're going to get a real good opportunity if you well organize to put in long-term remission a lot of these patients.
Okay, there is some literature support to say this, that by giving ADT and either abiraterone or enzalutamide or apalutamide, small percentage of patients can develop a pathological complete response. If you do radical prostatectomy, the disease will not be there. And a newer parameter has come recently, that minimal residual disease. If the minimal residual disease, for a bulky disease, if you treat with ADT and either abiraterone or newer agents for maybe 3 to 6 months, and when you do MRI, if the size of the lesion reduces to less than 5 millimeter, it's called minimal residual disease. They are going to do better. Maybe at 36 to 40 months, they don't fail biochemically. So biochemical recurrence is there. So what do you tell about that?
Yeah, that's what I'm telling you. I mean, we don't like to speak about cure because we know we can't cure this patient. But when you start reusing ADT and this drug in neoadjuvant treatment, you see exactly the same paradigm that we have discovered like 5-10 years ago with neoadjuvant chemotherapy for bladder cancer, where you have these patients with T4 positive lymph node bladder cancer. They got their 4-cycle on MVEC, and then you do the cystectomy. It's like you're removing a normal bladder. And when you look at the bladder, there are few residual cancer. We know that happened in bladder cancer. We have to realize that actually this is the same in prostate cancer. By increasing the efficacy of hormone therapy, we start to see extremely good response. And we know that if we administer the local treatment at this point in time, we're going to get excellent survival. So, and once again, it means that you're going to get patients with extensive lymph node, extensive prostate surgery. You say, wow, no way. And then we have here a clinical trial with ADT plus darolutamide. And we've seen patients, we've seen patients that even the radiation oncologist after 3 months say, you know, I look at the MRI of that patient to plan their radiotherapy, you know, the response is so good, we should rediscuss surgery. So that's why I say that more and more, we will not discuss radiotherapy surgery upfront.
Right.
We're going to start by 3-6 months combined therapy, speak with the guy, and then decide what kind of treatment we go. Surgery, and that's where I think we have the opportunity to have surgery alone in those, like you said, who have a minimal residual disease. Surgery plus radiotherapy if we see that we still have extensive disease, or go for radiotherapy alone is really the minimum. And what is interesting also is that, unfortunately, the patient who don't have any response to neoadjuvant hormone therapy, that, you know, you should not do surgery. You should, and radiotherapy will be okay, but you're going to have to go to chemotherapy and all of that. And that we see also exactly like in the bladder. In my center, if somebody is progressing on neoadjuvant chemotherapy, we don't do the cystectomy. We go immediately to second-line immunotherapy because we know cystectomy is a waste of time. And that's going to be the same. So you're going to use that kind of 3 to 6 months combined hormonal treatment to see, oh, the lymph node response, oh, the prostate response, and then adjust your local treatment. But you're going to create the opportunity of having more patients who only need surgery.
Okay. So we have discussed about all these newer agents. Is there any role of neoadjuvant chemotherapy, docetaxel, for locally advanced prostate cancer?
That has been extremely disappointing. I mean, the problem is, I think that the trial were not conducted well in a way that we were not able to well select the patient. We have done trial with chemotherapy right before, right after. There's been a trial in the US, Karim Fizazi has a trial with estracit and docetaxel. But actually the problem is that they were not real high-risk patients. So that's kind of complicated. So I think that at this point in time, it's not really hot. What is disappointing is the local control by chemotherapy.
Right.
The local control is not what we see with ABI, ANZA, APA. where the low. So we never use chemotherapy in locally advanced patients, or exceptional cases of patient with pure neuroendocrine cancer, which anyway are bad. But the traditional locally advanced patient, we don't use chemotherapy a lot. And that I know because I'm in the IDMC of Stampede. I know that in the UK especially, they have a few centers where they are aficionados of that approach, but I'm not too much. I think chemotherapy in locally advanced disease, we're going to need more data.
Okay. What kind of surgical planning you do for locally advanced prostate cancer, either upfront or after hormone therapy? And, do you foresee or do you anticipate any complications or problems during surgery? What precautions you take?
I mean, we don't, I say 100% are done with the robot now. So, I mean, we rarely have problem. The only thing is that we do, like I say, we do XXL prostatectomy. So we usually remove all. I mean, we go under the Dinonvilliers fascia, so like a cystectomy, and
Right.
we usually don't preserve the bladder neck because we had a few recurrence on the bladder neck, and that's hell. So we usually did, like, Professor Walsh was doing, a kind of a very, very large resection, trying to not cut into the ureter, and then we repair. So we do what, we do a traditional prostatectomy. We don't apply any of these nurse sparing procedure or, continence. No, we do it very simple and very wide. And we tell the patient that usually he's going to be continent, but that may take a while, more than somebody who would have a nice, Rocco procedure or whatever, that it's going to take 6 weeks to be continent, but we don't have a problem. So what we do it broad, and we do always lymph node dissection. That is very important. We usually go, if nothing is visible on, if nothing is visible on the CT scanner, we usually go up to the common iliac artery and we do the presacral. If we see something on the CT scan, then we tend to extend a little bit.
Okay. What kind of long-term overall survival we expect from this kind of a multimodality therapy, surgery, neoadjuvant?
I tell you, overall, I like to tell my patient that if they don't have visible metastasis, we can expect 75 to 80% to be alive at 10 years minimum. Mm-hmm. If they have a Gleason score which is 8 and the lymph nodes are negative, then you can go up to 85, 90%. If the lymph nodes are positive, you lose 10 to 15% overall survival.
Okay, so with this, we have come to the end of the first session. Ms. Kaustubh, if any questions are there in the chat box, probably you can.
Not yet, sir. You can make a request. The
audience can probably send your questions to the chat box so that we can ask Professor Tombal. Or if any audience can ask the question.
There is also a question which has come, sir. During radical prostatectomy for locally advanced disease, any indicators that would prevent you from going further or backing out?
Yes, once again, the sphincter. If we usually start by a preperitoneal approach, so we put the bladder down and we go there. And if we have the impression that the sphincter is fixed, then we don't proceed, because that's really the number one limitation. Sometimes people are asking.
Hello, Professor Tombal?
Professor Tombal, we lost you.
I think there is some.
I'm back.
Yeah.
It happens from time to time. So I was telling that the number one reason for stopping is the sphincter. The rectum is rarely a problem.
Have you excised part of the rectum whenever to, to give a better clearance in a given
We had
indication?
some, yeah, I must say that we had some traumatic perforation of the rectum, and usually when it's less than 2 centimeters, we just repair. We put something on top of it, and anything we can, and we just do a very strong anal dilation, and usually it's okay. It's only in 1 or 2 cases that we had to do an ileostomy.
Okay, you said lower retroperitoneal nodes are also part of locally advanced disease.
Yeah.
Have you considered retroperitoneal dissection, lymph node dissection for radical prostatectomy while doing radical prostatectomy in any of your cases?
Yeah, we had some extreme case in young people when we decided to go for extensive lymph node dissection, because I believe that if you believe that in safe condition you can get everything you see, you should do it.
Okay. And what kind of radiotherapy field you advocate in such cases?
So prostate plus pelvic bed. So that has been shown in Belgium. We have a whole, we have a guy which is very well known, which his name is Gert de Meerleer. He has really shown that prophylactic irradiation of the, so usually they go up to the common, to the bifurcation between the aorta and the common artery, because they have IMRT and the possibility to really irradiate selectively. It's not associated with increased toxicity, and it's really decreased the rate of long-term recurrence. So that is important. And actually we see it very well, because we may discuss later on, we lose a lot PET PSMA, and we rarely see pelvic recurrence when the patient has an extensive irradiation.
Okay. So you don't advocate radiation for the retroperitoneal region?
Yes.
Okay. Thank you, Professor Tombal. And
we have 2 more questions from Dr. Yuvraj, sir.
Yeah.
They are in the chat box. One is how to assess sphincter involvement pre-operatively, and how to manage prolonged lymph drainage after surgery.
So for the first question, I would say that the #1 way to assess the sphincter is clinically, meaning doing a digital rectal examination and asking the patient to contract the sphincter. If at this point in time, you should feel that the sphincter is going up and that the perineum is going up. We even had a patient, a physiotherapist who had made a small tool with 2 pieces of wood, and he was measuring how much the patient was, putting the pelvic muscle higher. If the patient has a weak contraction and the whole area is blocked, that's not okay. The second way to assess it is by doing urethral profilometry. There is a surgeon in France which is called Barret. He developed a technique which is called Barret et Chevaux, which is a technique of open prostatectomy. And he used to do urethral profilometry to everybody before surgery. And by doing so in difficult case, you can see whether but I would say that the #1 is to assess clinically. How do you manage prolonged lymph node drainage after surgery? The first and most important, we pray. The second is we put the patient on a low protein diet. And and that's something I see many times with my my resident. When the patient, they put the drainage in the back on the leg of the patient. Now, if you do that, it will never stop. You have you have to have the drainage bed collector maximum at the level of the hip, and it usually stops. It's very rare that we have to do alcoholization, or it's very rare. And consider salvage radical prostatic cystoprostatectomy. Yes, but not upfront. That's very rare. We have done some salvage radical cystoprostatectomy after failure for radiotherapy, but never upfront. But we have done, and we're still doing from time to time, especially now with PET PSMA, when we have extensive local recurrence after radiotherapy without positive lymph node dissection or without metastasis, we do 2-3 a year where we do salvage radical cystoprostatectomy. And we have some cases of patients with long-term recurrence, but it should remain an exception.
Yeah, the same question was asked by Professor Jagdish Kulkarni, who is a very well-known and senior uro-oncologist from Mumbai. He has asked the same question.
Yeah, and before it was always difficult because it was difficult to ascertain that it was indeed a pure local recurrence. Now with PET PSMA, if you do a PET PSMA and there is nothing else, then you're really comfortable. And then you know that in case of local recurrence after radiotherapy, you know that some of these patients, they are really miserable. They don't have any continence anymore. They have a mix of urgency, continence, retention. And you know that when they have a local recurrence, an apical local recurrence, that's a drama. There's nothing you can do. I mean, hormone therapy won't work very well locally. You're going to do transurethral resection. So usually we tell the patient, you know, the indication, it is not oncological. We can control your disease with ADT and other drug, but you're going to be miserable. So having a breaker in this patient is often a delivery. They have this component of, you know, at some point, and you have to be careful, because if you miss the opportunity and it keeps growing, at some point you're not going to be able to do it. So if you feel you have a pure local recurrence, that the tumor is progressing, that the patient has no metastasis, you have to be careful, because you have a window of opportunity when you can preserve the patient integrity, because otherwise that patient for the next and this is something they don't speak enough in the trial on the medical oncologist. This is all these patients we have in our clinic, which are miserable. They have JJ stand, urinary catheter, because they have not been properly controlled locally. So local control is even more important today than yesterday, because we can increase overall survival. So they're going to have basically to stay miserable for a longer period of time. And that's very important.
Yes, you're absolutely right. There is a publication in Brazilian Journal of Urology sometime back for a locally advanced prostate cancer after giving hormone therapy and radiotherapy. If they develop metastasis, almost close to 50% of them develop local symptoms. As you said, all these symptoms. So they may require some sort of a local treatment. It's very difficult to manage at that point of time.
Yeah, but look for instance at the look at the 3 trial in non-metastatic CRPC with apalutamide and enzalutamide. Go to the quality of life. We're going to look at the quality of life data. You're going to see that a lot of these patients have urinary symptoms. And even better than that, 5 years ago, we published a paper with Bayer, because Bayer was actually looking at demonstrating to physicians that metastatic CRPC patients have a lot of bone symptoms, that they don't speak to the doctor. It was part of a marketing process for Radium-223. It was a nice study. They have interviewed 500 patients and their caregiver. And actually the first symptom, the first bothering symptom that came was not pain, it was urinary trouble. So I think that in the last 10 years, this problem of local control has been absolutely disregarded. And when you're becoming CRPC and you have a pure local progression, the drug will make you live longer. They may improve your quality of life, but you're going to remain with your symptoms. So if there is an opportunity, I have absolutely no shame to discuss with the patient. I believe that having a well-working pouch is a valuable alternative. You have sometimes patient, you ask them, they wake up 10 times a night. They spend their life urinating, and you can deliver. You're not going to live them longer, but you're going to live them better. And to me, local control is not about living longer. It is primarily about living better by having less urinary symptoms.
Yeah, thank you, Professor Tombal. Ms. Kaustubh, if there are no more questions on LAPC, shall we move on to?
Yes, sir. There is just one by Dr. Ranjit Patil. Do you reject the patient for surgery if Gleason 8 or G8 score is low? Or what
Yeah,
is the G8 score for, what is the cutoff for of G8
12
score
in
for
our
surgery?
center. 12, especially if the score is high because of cognitive trouble, because then we know it's never going to be okay. So every patient above 75 is sent to a oncogeriatrician evaluation. If the score is about 11 or 12, then you do whatever you want. It's below than that, then the geriatrician will see how much they can improve the status of the patient, because sometimes there is some margin to be improved. If there is no margin, then we go to radiotherapy surgery, radiotherapy hormone therapy.
Okay. So with this, we have come to the end of the first session. Shall we move on to the second session, Professor Tombal? This is about oligometastatic prostate cancer. I would ask you to define what is oligometastatic prostate cancer. We know metastatic prostate cancer is there. Is it the early part of metastatic prostate cancer, or is it a different entity altogether?
So unfortunately, oligometastatic has become a very hype word. So basically, if you speak Greek, oligo means few. Okay, so and behind that idea, there is the idea that you could do something on the metastasis. So I think that there are 2 or 3 important elements I would like to share with you. So that is the patient here. So actually, unfortunately, we have created a strange situation with the incorporation of new imaging technology. That is that this is a typical high-risk patient, and more and more in my country, we would recommend either PET PSMA, PET choline, or whole body MRI. And we know that if we do that, we're going to find a lot of patients. I would say in our study, it was 30% of the patient. They have a negative bone scan, CT scan, but you see 1 or 2 metastases. And you see, we've shown, it's a paper we published in 2016. We basically show that 20% of the patient, you may either find abnormal lymph node outside the external lymph node standard template, meaning find lymph node here or there, and you will even find here. And you're going to find metastases also. And this is the same. I mean, but whole body MRI was quite, I mean, not many centers use it, but PET PSMA is becoming very popular. And they did that very nice study, Pro PSMA, where actually they show that you're going to find also in 20% of the patients. So actually the problem we're facing right now is that we have transformed the patient we just discussed for 1 hour into a patient with metastasis. Because if you take that patient here, 14.6 T3A, 1 small pelvic bone metastasis, you can already see on the MRI, and a negative bone scan, actually he's got no 3 metastases, 1 here, 1 here, and 1, I don't know where, somewhere. So what do you do with a patient like this? Because should you change the treatment? Because really the question is the following one. I mean, let's say that you had discussed that you would do surgery for that patient. What should you do now? Now that you know that he's got 2 metastases. So to me, that's the real oligometastatic. A real oligometastatic patient is a high-risk localized disease, or a patient with a rising PSA, where you've done a bone scan, CT scan, and it's normal, and you have access to modern imaging technology, which is going to come and it is no metastatic. It's very rare that you're going to find 25 metastases. Usually you're going to find 2-3 metastases. So to me, that's the first category of oligometastatic patients. So these are patients which are coming from non-metastatic patient, high risk locally advanced, for which you had scheduled local treatment, and eventually systemic treatment for a certain duration of year? Should you say, no, this patient is metastatic? And that I would disagree, because actually, if you go to the guidelines, they don't speak about that. The guidelines, the EAU guideline, they speak about M1. And actually, it's interesting. Do the exercise. They don't define N1 in a way that they say it's N1 based on that technique. What they say is that the standard imaging technique is bone scan, CT scan. So you can infer that this patient is not an M1, because to be an M1 in the EAU guidelines, you need to have a positive bone scan, CT scan, which is different. And so what he said that you should give either docetaxel or ABI or enzalutamide to these patients. So it's very complicated. So that's where, to me, we're starting now with these patients to have difficulty. So my recommendation for a patient like this is to treat him as a locally advanced disease. Why? Because we've done that for many years. And so a patient like this, I would keep going for surgery. I would decide afterward for radiotherapy. And then I would discuss with my radiation oncologist, and this is not in the guideline yet, is there an opportunity to irradiate these two metastases to have a complete treatment? Because actually, we don't have high evidence, but we have a series of phase 2 trials who actually are indicating that when you have limited extension, then really there is an opportunity to treat the metastases locally. So that's the first end of the spectrum. So these are patients that you've seen, and technically speaking, they are locally advanced disease. They have a negative bone scan, CT scan. And then you do a new imaging technology, and you find 2, 3, up to 3 metastasis deposit. That's the first group of patients. And for this group of patients, there are basically 3 questions. The first question is, should you treat these patients as metastatic and put chemotherapy, long-term ABI, ENZA, or should you treat these patients as locally advanced disease? Without any evidence, I would say you treat them as locally advanced disease, just the discussion we had. The only difference is that you discuss with your radiation oncologist to irradiate also the few metastatic deposit you see. That's the first question. And that's the first group and the most important group. So that for these patients, I have no problem. And we're going to learn more and more. But then there is another group of patients, which is the group of patients which actually has already metastasis to start from. So this is totally different, that somebody's coming to see you and the patient, let's say at 75 years old, he got a PSA 100. He's got a Gleason 8. You do a bone scan, CT scan, and you see less than 3 metastases on the bone scan. That's totally different, because that patient is metastatic. And oligometastatic here means that on the bone scan, CT scan, you see up to 3 metastases. That patient is metastatic. So he falls into the definition of the various trial here, Stampede, Charted, Titan, and then you should follow the guidelines, meaning that the reference treatment of a patient with a positive bone scan up to 3 bone metastases, the reference treatment is systemic treatment, ADT plus chemotherapy or second generation hormone therapy. And then you're asking the question, should I add local treatment? And then there are 2 questions. The first one is, should I add local treatment? And then you have no other choice than to follow the Stampede trial. And this is the latest publication, who show that actually up to 3 bone metastases, there is a benefit in doing local treatment. Is local treatment with surgery as good as with radiotherapy? I tend to believe so. There is a very nice trial in Belgium here. Prospective trial would basically show no major difference. So, but the philosophy is totally different. If you start it, so that's why everybody need to have a bone scan CT scan. Is the bone scan CT scan is negative, that's a locally advanced disease. You should have local treatment plus systemic treatment if needed. And if you do a PET PSMA or all body MRI and it shows metastasis, it doesn't change anything. You still should treat that patient as locally advanced disease. If you start with somebody who has 2 to 3 metastases on a conventional bone scan, the reference treatment is systemic treatment, ADT plus something. If he has less than 3 bone metastases, then you should think about local treatment, radiotherapy or surgery. And then come the question, should you irradiate the 2-3 metastases? That's where you should not do that if you don't have a PET PSMA. Because actually, if he has 2 or 3 bone metastases on a bone scan, there is more than 50% chance he's got many more metastases. So to be sure you irradiate everything, you need a PET PSMA. And actually, it's been shown by the Oriole trial. It's a very nice trial. It's in the rising PSA setting, but it's similar. It was oligometastatic patient based on a bone scan. So they irradiate everything they see on the bone scan. But they did a PET PSMA also that they didn't use. They look at it afterwards. And they show that actually if you have untreated lesion on the PET PSMA, so basically you had more lesion on the PET PSMA, your overall survival is very bad. Your metastatic free survival is very bad. So it means that in metastatic patient on a bone scan, whatever the volume, low volume, high volume, you should start ADT plus something. Then, if it is a oligometastatic low volume disease, it's the same, 3, 4 metastases, whatever, you should do local treatment. As for irradiating the metastatic deposit, then you need new imaging technology to be sure that you are irradiating anything. So that's, to me, the definition of oligometastatic disease. It's a very broad term. And to me, the most important is that you make the distinction between oligometastatic on standard imaging, bone scan, CT scan, and non-metastatic on standard imaging, oligometastatic on modern imaging technology.
Yeah. Thank you, Professor Tombal. You said oligometastatic prostate cancer patients do benefit from local therapy. So what kind of local therapy you are going to advocate, whether surgery or radiotherapy, and how are you going to discriminate which patient will go for what kind of treatment?
I would say that, to me, the local treatment, it's a little bit the same discussion. If the patient is like 65 years old, he's got a lot of urinary symptoms, is bothered by his urinary function, we would go for surgery. But in that case, we don't do any lymph node dissection because the benefit have not been shown. We just do a simple prostatectomy. The same for radiotherapy. If the patient is metastatic on the bone scan, oligometastatic on the bone scan, then we follow the Stampede definition. We do purely local treatment, okay? And then we decide. So that's really the idea. For locally advanced with metastasis on PET PSMA, then it's exactly the same we discussed a few moments ago. So that's the idea.
So you don't recommend pelvic lymphadenectomy when you're doing surgery for oligometastatic prostate cancer?
Yes, we do from time to time. Yes.
No, you do
because
you do pelvic lymphadenectomy, or you don't recommend pelvic lymphadenectomy when you're doing
well, usually we don't know, because we don't believe that the contribution of the lymphadenectomy is the same that in the locally advanced disease. And we are waiting for the result of the Stampede trial where they have irradiated the lymph node to get more clarity on this. But once again, if we have a low, I prefer to use oligometastatic for patient with negative bone scan, CT scan, positive PET PSMA. And I prefer to use low volume metastatic disease for those with up to 3 lesions on the standard imaging. For these patients, for which we know if you do a PET PSMA, many times you're going to find more lesion. For those patients, so low volume metastatic disease or oligometastatic disease, when we treat the primary, we just treat the primary, either radiotherapy or prostatectomy. For the metastatic deposit, we still put the patient in clinical trial and we rely on a PET PSMA.
Right. You said in a younger individual, you do, radical prostatectomy and metastasis directed therapy. If 3 bone mets are there on PSMA PET scan, you're going to irradiate all the bone mets. Are you going to
on
consider,
the PET PSMA, we would do it.
Yes. Are you going to consider radiotherapy to the pelvis in case after surgery, if margins are positive, if your lymph nodes are positive, are you going to suggest radiotherapy to the pelvic area?
Wonderful question. We have debated for 10 years. As you know, there was a UK and there have been 3 trials. They all they're not very positive. And once again, today there was that beautiful editorial. I'm going to send it to you so you can circulate it in Lancet Oncology, that position paper by de Merler and other, where they tend to encourage immediate irradiation of the lymph node area. So that is really a moving target. So we do it on a case by case, based on what? Based on the extension of the lymph node dissection, on the number of positive lymph nodes. So that is a very, very difficult topic, which is, should you irradiate the lymph nodes after surgery? So it's very, very difficult. And I must say, I don't have general rule. I tend to recommend that we do it more and more because the radiation oncologists have the ability to really be precise. But if you look in the guidelines, it's very weak evidence.
Okay. What are the long-term outcomes when you consider local therapy, surgery versus radiotherapy?
Nobody knows.
Nobody knows.
I like to tell my patient that I started my training in 1991, and that was easy. The patient would come to my boss, and if the patient was young, rich, and beautiful, he would have a prostatectomy. If he was old, ugly, and poor, he would have radiation therapy. So when you look at comparing the survival, you compare the survival of the young, rich, of beautiful, of those that are ugly, poor, and not in good health. So every time you try to match the patient as much as possible, I really believe that what makes the difference is quality control. Did you have good surgery, good radiotherapy? So I tend to say that, to me, the reason why I advocate surgery is not a matter of overall survival. I try to tell the patient, listen, we're going to make it easy. We're going to say there is no difference in overall survival, okay? Then let's see, why would you get surgery? Why not? And that's where local control, symptom controls, stopping the local progression come into the discussion. And my impression, and we have here in follow-up, and I've done so many trials in the metastatic CRPC, I've seen so many patients. My impression is that the proportion of patients with local problem is lower when they had prostatectomy in good condition to start with.
We have only 10 minutes more. I would like to ask you a few questions. How would we be treating oligometastatic and locally advanced prostate cancers 10 years down the line?
Oh, I think that is going to be. I think that is going to be the full Monty. So clearly, I'm speaking here about people normal age, good condition, and let's not speak about the exception. I think that in 10 years from now, we're going to start with ADT plus something, okay? And APA, whatever. After 6 months, we're going to look at the local situation. We're going to treat the primary, surgery, radiotherapy. I think that in 10 years, we're going to still have that discussion, radiotherapy, surgery. I think that the difference will be the PET PSMA. I mean that if we have PET PSMA and they are PET PSMA lesion, instead of doing metastatic targeted therapy, we're going to do PSMA targeted radionuclide. They have started trial like this in Australia, where actually instead of waiting that the patient is castration resistant, they treat upfront with drug like PSMA lutetium. So I think that in that category of patient, which are the low volume, locally advanced oligometastatic, we're going to be extremely radical. And it's going to be like breast, like rectum. And I think that then we're going to get an opportunity to.
So I'm going to throw you a hypothetical, question and situation. A young patient comes with oligometastatic prostate cancer. A couple of bone mets are there, 3-4 bone mets are there, and retroperitoneal and pelvic lymph nodes are there. He doesn't want surgery or he doesn't want radiotherapy. Do you advocate PSMA actinium therapy for him?
If it's PSMA positive, I would actually, I think that we're going to see that more and more, because I think that PSMA lutetium, as you know, it's a beta emitter. So it still have a lot of toxicity. So we've seen some patient with dramatic thrombo, but when they're going to be able to first come with better PSMA antibody, and second, be able to hook it to alpha emitters, such as actinium radium, then that's going to dramatically impact the way we treat these patients. But once again, and that's very important, that's going to put surgery on the front line, because there's a huge trapping problem. And if the prostate is in place, you're going to probably miss a lot of, because you have a concentration problem. It's not like radium. Radium, 95% goes in the stools. The PSMA, there is an affinity. So if you look at all these patients, actually all these PET PSMA patients, the prostate, it's flashing. So I mean, it's going to be hormone therapy, local control, and then the consolidation will come with this treatment. And I think that more and more we're going to use this treatment as adjuvant. Now, when the patient is going to skip radiation therapy, we're going to use it alone. But I think that more and more, this will become a very good adjuvant treatment. And then we're going to come back to the beginning of the circle, and basically to ask question about, do we still need the more toxic treatment? And the more toxic treatment is androgen deprivation therapy.
Yes.
So more and more, we have a study where we do radiotherapy. We have an EORTC study, which is radiotherapy plus darolutamide versus radiotherapy plus standard ADT. I can tell you, in terms of quality of life, I mean, that's amazing. I mean, and the PSA response rate are amazing. So I think that in the next 10 years, if money approved, because then the main limitation will be financial, we're going to get out of androgen deprivation therapy. I decided that I will not die unless we still use androgen deprivation therapy, because I think that with the drug we have right now, with the technical capacity we have in surgery right now, with the improvement in radiotherapy right now, it starts to question the most important question: what is the remaining role of androgen deprivation therapy? Which for these men, in the end, that's always what they complain. So that's where we're going to be in 10 years from now. And actinium PSMA, and
Professor Tombal, we lost you.
He has a network issue, will come back again.
Professor Tombal, are you with us?
Hello, I'm back.
Yeah.
From time to time it happened. We are not as developed. I know that in Bangalore you've got the number one. If I call the help desk, it's going to be in Bangalore. So I say, let's wait a little bit. The number. I mean, in Europe we are far behind India in IT. That I realize, and even far behind China. So no. So I think that this PSMA targeted drug will become key. And we just publishing a paper on the discordance PSMA negative, PSMA positive lesion. And actually you don't find that at the beginning of the disease. So I think that the way it is given right now, it's too late. And what is good also is that there is no patent protection for these things. So everybody can make his own PSMA actinium. I mean, here we have started to make our own PSMA lutetium, and they start to work on beta nucleus. So there will be not such a huge commercial pressure. Everybody can be able. Yeah, we're going to get problem to buy the nuclear compound. That's something else. But because actinium, as you know, is very dangerous. So the importation in Europe is heavily controlled since they killed the Ukrainian president, that the Russian killed the Ukrainian president with that. So because of that, there is a lot of issue. But as a treatment, it is unbelievably efficient. So that's going to change the way we treat these patients.
The only biggest challenge with actinium is within 24 hours, they become totally, their mouth will become totally dry. They become
and it's becoming extremely dangerous, because then it's becoming polonium and all these and then so they
as of now it is irreversible.
Yeah.
As of now there is no treatment for that except using some lubricants. That is the only drawback of this. Any long-term adverse effects of this nuclear medicine, these molecules?
Listen, I've been doing a lot of Radium. When Radium came on the market, everybody say, "Oh, you're going to get second cancer," and all of that. I'm PI of the Reassure trial. We have treated now 1,500 patients for 9 years. We haven't seen more cancer than in the general population, and there will be PSMA lutetium surveillance. So long-term toxicity, we are speaking about patients who are not in such good shape. So I don't believe that's going to be the issue. Look at, radiotherapy also, radiotherapy for testis cancer. There is an increase in the cancer rate. I wouldn't be too worried about that.
My last question, we have only 2 minutes. Is there any role of genomics, proteomics in selecting the patient for a particular treatment?
I would say overall, it's been quite disappointing. If you look at the real benefit of spending a lot of money in understanding the biology of the cancer, look at all these splice variant and all of that. Basically, you don't need splice variant to know that you shouldn't use ENZA after ABI and vice versa. I think the only exception will be the really targeted therapy, like PARP inhibitor. Then you need to get BRCA status. PI3 kinase inhibitor, like ipatasertib. But for the rest, I usually tell people, if you have $1,000 to spend, I would spend it in a new imaging technology and not in a new biology test. That would be my view. I mean, we get more by imaging that we get by genomic. Genomic is very hype, but still the real benefit in an everyday practice is still kind of limited.
So there is one question from Professor N.P. Gupta as a senior.
I see it.
If PSMA PET is available widely everywhere, which is available in India at most of the major cities, then why do bone scan and CT scan? Why not?
Actually, we do it the other way as well. So meaning that every high-risk patient, so every patient with a high-risk characteristic, we do a PET PSMA. And we ask a bone scan when the patient is high volume on the PET PSMA. Why? Because then the definition for local treatment still is based on the bone scan. So let's assume we're doing a PET PSMA, the patient has 3 metastases on the PET PSMA, he doesn't need any other exam. If the patient has 10 metastases on the PET PSMA, then we do a bone scan, because then the decision on the local treatment depend on the number of bone metastases on the bone scan. So that's complicated. But if the patient has a negative PET PSMA, or it shows only lymph node or 1 or 2 metastases, you don't need bone scan, CT scan anymore. Certainly not CT scan, because you've got your CT. And you're going to see a lot of small things. So no, I'm absolutely right.
Yeah, thank you, Professor Tombal.
You're welcome.
9:30. Do you have any final message to Indian urologists and uro-oncologists?
It's a great time for urologists. I mean, when I came back from US 10 years ago, everybody was telling me, you know, urologists, you're going to get replaced by radiation oncologists, by medical oncologists. So my message is that the young urologists, they have to learn to administer the drug properly, because surgery will remain very important. So as a oncologist, we are still the gatekeeper of that disease, and it should remain like this. So we really have to study, and for us, the next 10 years will really be exciting.
Thank you, Professor Tombal. We have come to the end of this whole program.
Thank you.
Thank you, all the delegates. Thank you, CIPLA, for giving this opportunity. And thank you, Professor Tombal, for giving a lot of insights on this difficult topic. You know, there is no, standard guidelines are also not there how to manage all these things. So thank you. And now more than 500 delegates have participated, and more than 150 from abroad, and more than 35 uro-oncologists have participated in this webinar. And it's indeed a pleasure to have you to understand this difficult topic. I thank you once again. Thank you, CIPLA. Over to you, Mr. Kaustubh. Kaustubh? Hello? If any questions are there, probably we can take up, or we can wind up the session. Kaustubh? Anyway, thank you, Professor Tombal.
You're welcome. Bye-bye.
Bye-bye. Bye.